Good morning, students. Today, the topic which I'm going to take is Tmj dislocation and subluxation. It's a very interesting topic regarding our Tmj. So, what do you mean by dislocation? By going by the introduction, dislocation occurs when the condyle moves in a position anterior to the articular eminence. Okay, articular eminence is seen in the skull base. Okay, so when the condyle slides over the articular eminence, and when it is not able to come back, it's called an open lock from which it cannot be voluntarily reduced. So dislocation means the condyle is completely out of the fossa, condylar fossa, just past the articular eminence, and it is not able to voluntarily get reduced. Okay, so there are three types of dislocation. One is acute, second one is chronic, or it's also known as subluxation, and another one is your long-standing. Okay. So what do you mean by acute dislocation? In acute dislocation, episodes of opening locking that last for a short duration before reduction. So acute dislocation means there will be an open lock that lasts for a short duration before it gets reduced. Okay. What do you mean by chronic and habitual dislocation? It refers to, as the name suggests, habitual dislocation means it refers to recurrent dislocation and reduction that the patient can cause at will. The patient will be able to slide the mandible forward as well as can over the articular eminence, and then he himself or she herself can bring it back to the normal position. Okay. So the main difference between acute dislocation and chronic or habitual dislocation is one is the patient, it is an episode of short duration and you'll have an open locking. The patient won't be able to bring it back. Okay, so that is what it is called an acute dislocation. This happens when people tend to yawn while doing any procedures like RCT, where the patient will be keeping their mouth open for a long time, and automatically it comes out of the fossa, slides over that, and they won't be able to close them. Okay. Third one is your long-standing. It occurs when the condyles remain lodged anterior to the eminence for a period of time. Usually it exceeds excess of 3 weeks. Okay. The long-standing means the period is over 3 weeks. The condyles remain lodged anterior to the eminence. So we have come across acute dislocation, chronic or habitual dislocation, and long-standing. Long-standing is nothing but when the condyle remains out of the fossa, lodged anterior to the articular eminence for a period of time of more than 3 weeks. Okay. What are the predisposing factors? So what are the factors that can lead to your TMJ dislocation? One is your laxity of temporomandibular ligament and joint capsule. So this predisposes to the dislocation. Okay. The TMJ, temporomandibular joint ligament as well as joint capsule, predisposes the joint to dislocation. Subluxation or dislocation are frequently caused by combination of your TMJ gets overextended and dysynchronous muscle function. Okay. Subluxation or dislocation are frequently caused by combination of when does the TMJ get overextended? When you are yawning or when you are doing any procedures in a patient's mouth where you tend to overlook how much the patient is opening his or her mouth. Okay, so these are the conditions where we will have to be very careful actually. You should ask the patient whether he needs any rest. Okay, so any overextension can create trouble for such type of patients actually. Okay, and dysynchronous muscle function. Dysynchronous muscle contraction results from alteration of the normal contraction sequence of protractor or elevator muscles. Okay, either the protractor, which helps to bring the mandibular forward and backward. Okay, protract and retract muscle and elevator muscle of the mandible are the basic culprits for your dysynchronous muscle contraction. Okay, coming to the clinical picture, how does it look like? Acute dislocation, any person knows when is it acute, anything acute will be painful, right? Okay, so acute pain in the affected joint and associated muscles of mastication. If it is bilateral, the mouth is held open. Mouth is held open, then the patient will have anterior open bite and it is in protruded position. Muscles are tense, excessive salivation will be present, then mandible with restricted range of motion. Okay, if it is bilateral, definitely the patient won't be able to close his or her mouth. There will be excessive salivation and they won't be able to put it back. And there will be a restricted movement of the range of movement for the mandible. Okay. And in unilateral dislocation, the mandible is open and is protruded towards the opposite side. Okay. So one is out of the condyle fossa, the other condyle is normal. So if it is unilateral dislocation, when the patient tries, excuse me, when the patient tries to open his or her mouth, the mandible deviates to the opposite side or the normal side. Okay. The teeth cannot be closed in occlusion and held further open. They won't be able to get a bite properly. So they won't be able to bring the teeth into occlusion and it held further open than in bilateral dislocation. Understood? The acute dislocation, there will be definitely pain in the affected joints and associated muscles. If it is bilateral, then mouth held open in protruded position, muscles are tense, there will be excessive salivation present, mandible with restricted range of motion. Okay. If it is unilateral, then again the condyle is out of the condylar fossa in front of the articular eminence and it tends to deviate onto the opposite side. Okay. Then the teeth won't be cannot be brought into occlusion. It will be further held open than in bilateral dislocation. Any doubts? Then you can always palpate the preauricular area, which reveals a hollow space anterior to the tragus with the condyle palpable anterior to the articular eminence. Okay, it's the easiest way because wherever the TMJ is, when you try to open or close the mouth, you can feel when you palpate, you can feel that the condyle hitting your fingers actually. Okay, so you can appreciate the movement. But when dislocation, you won't be able to appreciate that particular movement. The condylar position will be anterior to the eminence. So definitely there will be hollow space below in the preauricular region. Okay. The corner process is palpable inferior to the malar bone. Okay. Since the mandible is completely out, the corner process is palpable inferior to the malar bone. That is your zygomatic bone. The capsular structures are tender and quite painful to palpation. As everyone knows, that any acute this thing can cause tenderness and pain to the joint. Okay. So when you palpate, there won't be condyle in the condylar fossa. Okay. It will be anterior place. So these are the photographs which you can see. One is the patient who is down has got an open bite. So it is bilateral dislocation. Whereas the patient on the right side of the screen, it shows unilateral dislocation. You can see, you can appreciate the deviation of the mandible to the normal side. So this is an OPG showing the condyle, mandibular condyle on both sides completely out of the fossa. And on the left side, you can see it is completely out of the articular eminence. Okay. So this is another view where the condyle has come out of the fossa above in front of the articular eminence. So how do you manage? Overcome the severe muscle spasm. Okay. First of all, you should talk to the patient that nothing is wrong. Try to be calm. Okay. So that the muscle spasm gets slowly reduced actually. Once the anxiety is increased, what is going to happen is the muscles tend to be more tense actually. Or muscles going for more spasm actually. So you have to reduce the anxiety. Okay, and reassure the patient. You can give sedatives or anti-anxiety muscle relaxants. Okay, you can even use some slight sedation like a diazepam. Okay, then it can be manipulated with or without LA. Okay, or if it is very severe and long lasting, definitely it goes in for GA. GA can be reduced. So these are the, excuse me. So this is a photograph showing how to reduce a dislocated mandible. Okay, so the patient you stand in front of the patient. Okay, it's an intraoral route. You glove with a thick gauze tapered securely on both the thumbs. You place it over the molars with, on the ridge of the mandibular intraorally, posterior to the molars with the fingers wrapped externally around the mandible. Okay, so your other fingers will be holding on to the lowermost portion of your mandible, whereas your thumb will be on the occlusal surface. The patient position, mandible is below level of your elbows. Apply firm, slow, and steady pressure. You have to place the mandible down first and then slowly slide the mandible posteriorly. Okay. If bilateral reduction is not possible, you can reduce one side at a time. Okay. That is slowly downwards, backwards, and upwards. Okay. So you can see the photographs. Okay. You can see the thumb inside the oral cavity on the molar region. The patient is sitting with the mandible parallel to the floor, with the operator in front of the patient. Okay, with his fingers across the lower part of mandible. Okay, bringing down to another view of the G. If you don't wrap your fingers, what is going to happen is you can see the patient bite onto the operator's fingers actually. So definitely you have to wear a glove, cover it with good amount of gauze piece so that while reducing you won't get a patient's bite. So now we'll stop here. Okay. So next class we'll continue with subluxation. Thank you for your patient listening. Okay. If you got any doubts, you can ask any questions. Okay.